I'll also like to invite on stage the panelists, Dr. Ranjani Ramachandran from the WHO India office, Dr. Ankur Mutreja from PATH, Dr. Naveen Shah, the Chief Controller NTCC Nepal, Miss Amy Steadman from GFI Labs, and Dr. Bharati from the Union office. Dr. Ankur is not coming. We do not have Dr. Ankur. Instead, we have Dr. Sachin from PATH. Sir, over to you.
Thank you. Uh, so we request the panelists to please take the seat, ma'am. And please. Good afternoon, everyone. Thank you for joining this important discussion on innovations in sample collection and transportation. So, as we all know, accurate and timely diagnosis is the foundation for effective TB elimination. So, still sputum-based testing continues to be the gold standard, but the efficiency of collection and transportation determines whether a patient gets the diagnosis at the right time. So, there are lots of challenges still remains in that domain. Delays in collecting and transporting sputum samples lead to missed diagnosis and also loss to follow up and continues the transmission. In remote areas, the sample transportation can take days, affecting test accuracy and delays in treatment initiation. And also, like, there are challenges with cold chain transportation, sample contamination, and inadequate logistics, which further complicate this process. So this is where innovation becomes critical. And in this context, we need scalable, cost effective, and efficient solutions that can strengthen the access, timeliness, and reliability of sputum collection and transportation. So, as you all heard yesterday, the program is trying to improve the coverage of molecular testing. But to see that the samples reach a molecular test, it should be in a proper position and it should be in a proper condition. So, for that, we need solutions and innovations which would be able to take care of that, so that we would be able to achieve the coverage of molecular testing, so that we can move towards replacing smear with molecular tests. So for that, we need innovation in this domain of sputum collection and transportation. So we have esteemed panel of experts who will share their insights on these critical questions. So first we will start with Dr. Ranjani madam. So madam, what are the major bottlenecks in the current sample collection and transportation process that you think that innovation needs to address, ma'am?
Thank you, Sriram. So, the biggest problem for us is that to move the samples from where the patient is or the person is, from especially rural areas, but there are two different problems. In the rural areas, there is a different barrier. In urban areas, there's a different barrier. One of the things that the program really has tried to innovate or do some things is that to develop sputum transportation systems by initially, if you remember that in the RNTCP days, there used to be something called as an NGOPP scheme, where districts were allowed to work with NGOs who would do the transportation of samples from the periphery to the especially when smear microscopy was still the norm for diagnosis of TB. So, collecting it from patients or collecting it from centers that were not DMCs to the center where the microscopy was available, and they would do that. Then we moved on to the next level where states were encouraged, especially when the PMDT program was introduced. You may recall that we encouraged that states look out for other agencies like private couriers or the postal department to actually move the samples. There are two three important things, especially unlike blood samples, with TB samples, our biosafety issues and how we can actually send the samples maintaining the biosafe norms when you move the samples from the patient to the laboratory. Now, there are different levels across which you have to move the samples. One is that you have to move the samples for, you're still having microscopy. It's not like everything has moved to NAT, so you are still having to move samples to microscopy. You still have to move that. Microscopy has been done, then you have to move the sample to the NAT site. Once the NAT is positive or you have a resistance, then you have to move it to the reference laboratory, or sometimes even to the National Reference Laboratory or to the Medical College Culture and DST labs. So you have different levels of where you need to do the transportation. Now, in the transportation, when we moved from microscopy, which was just cup based and other things, which was much more easier to move, once we moved to molecular, we wanted them to collect the samples, and two samples which was from to be collected on the 50 ml conical tubes, so that they could be actually moved on a sequential manner from the NAT sites to the laboratories. Now, what happens is when the guidelines were developed and we were trying to help them to understand how to move samples, because this I want to really point out because of the issue of cool chain, which we require if you want the samples to also be tested on culture. Now, there were two different understandings that happened in the field. Because on one hand, we were telling, okay, it's a NAT based test, so we are not really concerned about maintaining cold chain. So you can just send the sample because it's DNA. We are not bothered anyway. We are going to denature the sample, and that's not a problem. Then on next line, we will say, no, 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 the same sample has to be moved for culture, which means that you have to maintain a temperature of at least below 25 degrees so that you prevent further contamination and things. So this actually then created a major issue that people decided that they'll do only one sample. Okay, and then what would happen is that that would go for microscopy and NAT, and then after that the second sample would never be collected, and the follow-on tests for LPAs and culture never happened for a lot of patients, because actually you had to go back to collect the second sample from the person. So these were some of the challenges that we have been facing for quite some time. The major issue is that who is going to move the sample. Now, districts are at a loss, because we actually tell the DTO, now it's your problem, now you have to find ways to move the sample. So different states came up with different things. In fact, when the PMDT program really scaled up, they did have this courier mechanisms. They were really moving it. But that was easier because it was all coming to the state headquarters. So courier agencies were willing to, you know, uh, move the samples because they had the networks to move these samples. But when you want to do it in remote peripheral areas, you really don't find couriers. Okay, and of course you have the post offices even in the remotest village, but then that does not really tell you that you can do TB samples, because there's always this concern about the infectiousness of the sample, because especially if it's sputum. So for us, I think if we really want to think about addressing these barriers, we need to have a clear understanding of what sample where, how we will move it, and identify what are the barriers which are very district specific. So what I can choose for, let's say, in a city cannot be chosen for a rural district, and even in rural districts some of them are very well connected, some of them are not. So basically a context specific transportation mechanism will have to be developed, and this is where we are struggling, because when we write generic guidelines, it's not really applicable in all places. So we are finding it difficult, and people in the difficult to reach districts, let's say in tribal districts, are finding it very difficult even to find a courier. You can talk, you can say yes, you can do by courier, you can do by Amazon, you can do by that. All that seems to be working in urban settings or where you have good connectivity, good roads. Yes, it's not that it is not, it's impossible, but there are all these barriers that seem to be even from the collection receptacle, where we find that sometimes they are not able to get source the conical tubes. They are collecting it in small you know uh, sputum collection, small containers, which doesn't have a good lid, so it's leaking. So many of these things seem to be uh, really hampering our thing. This is related to sputum and pulmonary samples. Then we move on to this big plethora of extrapulmonary, where you have anything from a small tissue like lymph node to the most precious sample of CSF, where you want the result to be available immediately. Agreed. If you are in a medical college where you have your, molecular test within the campus, you can just, rush it, even send it through somebody to get it done. But what do you do in other places? How do you really get all this done? How do you move these samples? Who is there to collect these samples, first of all? So we say that it's very easy to do an FNAC. When you write, it's very easy. But when you actually want to take out these samples and send it, how do you do? Even in district level, it is becoming difficult. So I think somewhere we really need to have an innovative way of actually doing some of these things. Some of the skill sets, I will talk about it if we are talking about what are the solutions for it. But currently, I'd like to stop here regarding what are the challenges that we have in terms of collection and moving samples.
Thank you, ma'am. So, the important point we need to understand is, so what is the purpose for which the sample is being sent, and understanding the local context, how the sample can be moved to the place where it is going to be tested. So here we have to be open depending upon what area, terrain we are working on, and we should be able to see, even if there is a bus transportation that is available, we should use that. Even if it is a air transport that is available, we should use that. But we should be ready to explore all the possibilities and try to see how we can use that. Thank you, ma'am. So next I would like to move to Dr. Bharati, ma'am. So what is your opinion on these challenges, especially in terms of sputum collection or sample collection?
Okay, thank you, Sriram. So let me get back a little bit to the basics and some different scenarios. So whenever speak of sample collection, the first thing comes to our mind is sputum, right? Because that's what we have always focused on. And we always say that collection may be at the health facility, collection may be at the doorstep. And of course, in hard to reach areas, there are different ways how we collect. But let's not forget there are two more scenarios around this. One is, and when I'm saying this is because there are gaps in these areas as well, is one is the private sector, which we always talk of engaging with the national program. We want the maximum notifications coming to the program. And also, let's not forget the pandemic. So, we have gone through a phase where we have seen and we have declared that we lost a good number of cases who were supposed to be detected during that period. And not only the new cases, but also those who were on treatment lost to their follow ups because there was no mechanism of sputum collection and transportation. So, going to these challenges and bottlenecks, my major concern here with my personal experiences, even if we put the systems in place, so even if you have a model where you can bring in the samples from private sector to the public sector or from doorstep to maybe to the lab or from tribal areas to the lab, the major issue remains the quality of the sample. And that is very critical because we know that if you have to detect a positive case, the quality of the sample is the most important. So one of the biggest challenge now, and especially when we are moving to models like active case finding, door to door, vulnerable population screening, things like that. So quality is something we really need to focus, and we are really lacking on the quality. That's one thing. Second thing is accessibility. So we still, though we say we have say 700 plus machines, we know that there is an accessibility issue. We know there is an problem with the timings of the lab. There is a problem with the hard to reach areas, and this is a gap which we have still not catered to. We have not still come up with the EPTB cases, as ma'am has already mentioned, that we are only thinking of sputum. There is a lot more there. There are states which are more on EPTB cases. They have high proportions of EPTB cases as compared to the pulmonary TB cases, and we don't have. And these are basically the hilly areas I'm talking about, which need the most innovations to see how these EPTB cases are captured. So I think these are the three critical things which we have to keep in mind: the quality, how do we reach out, and then the timely reporting back. So even if you take a sample and you're going and giving it in the lab, is the person getting the feedback? Is the private practitioner getting the feedback? Does he know what happened to his patient? Does the chest symptomatic know that I have been tested positive? So all these are still some major gaps which need to be addressed.
Thank you, ma'am. So the important point is the quality of sample that we collect. So we need to see how we address that. Even if the systems are in place, but if you don't get quality sample, then we would miss the diagnosis. And also the information how the patient is getting back his results as early as possible. Thank you, ma'am. So now I would like to start with Dr. Sachin. So what is your experience from the private sector on, so what innovations is your organization doing to address these issues?
Thanks, Dr. Selvaraju. Just wanted to set the context here. I'm just filling into the original speaker, Dr. Ankur Mutreja, who is from PATH, and I'm Dr. Sachin Gupta. I represent PATH here. So, just for everybody's understanding, PATH has been associated with TB programming for almost more than a decade now. We supported and developed a very award-winning program, which everybody knows, which is the PPI, the Private Provider Interface Agency, which was in Mumbai with the support of the Gates Foundation. I personally believe that program gave us a lot of learnings, a lot of insights into how the TP programming works and what are the challenges that we need to look at. We all know that microscopic confirmation for a TB diagnosis, let's say for a sputum sample or extrapulmonary samples to come up with a real diagnosis, what is the bedrock of the National TB Elimination Program. But during the experience of implementing the PPI program, we came across a lot of challenges. And the major challenge out there in Mumbai as well was inconsistent maintenance of records for the samples, not just for transportation, but for the records as well. And actually, that happened to be a major, major challenge. Um, what we kind of did it by getting in this technological innovations, we actually introduced a QR code. This was a technology that really we kind of addressed the automation, not just for the validation and transportation of the samples, but also kind of created a digital labeling for the samples. um, what really happened here is that once we did that, we connected the places where the samples were collected and then were taken to the diagnostic places. We connected them and got the QR code implemented. Through that, we actually took care of a lot of human errors that came through. We kind of expedited the kind of test results that came in. And because of the technology, we kind of automated the whole process into getting all the samples and the records collected into the Nikshay system. There was also a challenge on the log, on the temperature and the data related to sampling that got also addressed through that QR code solution. Another solution that Park worked with was in collaboration with Everwell, who actually had developed the Nikshay platform and the kind of digital solution. What we tried is linking the CBNAT results, the TrueNAT results, and also the computer aided determination software into Nikshay. Basically, so it kind of provided a real-time diagnosis of the test results to the service providers, which again reduce the time for waiting for the results, making it available to the practitioners at the latter stage. And it was helpful in reducing the diagnosis and the treatment time. So it kind of expedited the whole process. There are a couple of technological advances that we introduced in the program that has really helped. And I'm happy to say that both the solutions are actually now incorporated into the national program as well. So that was a learning which we had since the 10 years or more than a decade of experience of implementing the TV program. Thank you so much.
Thank you, Dr. Sachin. So the point is the data that we collect for sample collection and transportation. So in many situations, if we do it in paper and we have to enter the same information multiple times, and also there are chances and scope for error. So there are digital innovations as Dr. Sachin mentioned. If we are able to do that and incorporate into the mechanism, there is a scope that we could minimize the error to most possible extent. And also we could also be able to see that the results are conveyed, the tracking is possible. So all the solutions could be made available to all the stakeholders, starting from the patient to the end users. So that would be another way to see that how we reduce errors and improve the turnaround time and also track the results. So next, I would like to go to Dr. Naveen. So Dr. Naveen is from Nepal TB program. So we would like to hear from you, sir. What are the bottlenecks and interventions that you're doing to overcome those challenges in sample collection and
Sure,
transportation?
thank you. So Nepal, mountainous country, you everyone know. So this topic is very relevant to me. Like in 80% of the Nepalese land is just a mountain and hills. So there is lots of challenges for this sputum transportation. Even collection is there a challenge, but transportation, not only the sample, but even the human transportation is very challenging in Nepal. Because in a remote area there is nothing. You can see there is the lab there, but if you go there, it will take around 5 hours or 6 hours to arrive there. So these are the things, and we do not have the proper courier mechanism in the periphery, in the mountains and hills. So it's very difficult for them to transport sample from one place to other place. Also, we have the limited labs, so we cannot establish the lab everywhere because of the resources and manpower also. So it's a very challenging, like how we can tackle these sputum transportations. So we have lots of uh, other agencies who are helping in these transportations and collection also, but that is not enough actually. And we are trying our best to improve this sputum transportations. Like once we have used the drones also, and we already have two drones in our ntp, supported by some agencies. So drone also have lots of problem. Last just yesterday I see the drones over in this exhibition area. Initially they also feel a problem, like they cannot go very far if there is a lack of this air atmospheric pressure. So that is one thing. And also the weather is also another difficulties. So now the drone has improved, like their thermocool or something that cannot destroy this atmospheric pressure or something. So in future, but definitely it's expensive also. Like but even expensive, it has helped a lot to the ntp when it was under use. Like if it takes 2 or 3 days to transport the samples, it goes only in the few minutes or few minutes only. So there is lots of good things for these drones also. But definitely to transport samples, we do not have the proper courier channels. And also this is a biohazard material, so it has another difficulties to transport it. So we are talking with the many authorities, like how we can overcome these biohazard materials, these transportations and everything. So we have done, but still we need lots of improvement in our program. In collection also, sometimes if you have collected the samples and not stored properly, like a temperature control or something like that, then it has no matter, and it's very difficult to store it in a temperature that is required for even a genetic test. So it may get destroyed, the samples may get destroyed or something like that. So lots of challenges is there in a country like Nepal, where there's lots of mountains, but still we cannot establish our labs in periphery because of the low populations in the mountain area. So we should strengthen our transportation system as much as possible. So we are trying our best. We have think many things like the drones and others also. And just yesterday I see some tv send card in the exhibitions area. That is also a things which can help in the sample storage and transportations. But the thing is, we need to validate it in a wide levels, not only in a very small places. And we cannot, every country has their own scenario which is different than here. So we have to also validate these things in a wider range, so that it will help in the future. So that is from my side.
Thank you, Dr. Naveen. So, like in India, also like they have tried drones in Himachal and they have found it useful. But the scale up is a challenge because we need to see how, in which place we need to apply that, and what whether it is cost effective. So that determines how scalable it is. So, but it is context specific, that is useful, because in low population we need to see they are also screened and they are also taken care, so that they don't become future reservoirs for disease. So, thank you for that important point. Now I'd like to move to Dr. Emi. So, what is your experience in global scale during this your research on sample collection and transportation?
Thank you. First of all, thank you for having me here. It's a pleasure to be here. Um, I've actually been working quite a bit with non-sputum specimens, specifically with oral swabs, tongue swabs. And then more recently, we've shown that you can actually use swabs to sample many different specimen types, which creates a single workflow that can be used for multiple CBNAT tests. So one of the things I'm excited about is some of the new innovations that we've seen, particularly in the session beforehand. Hopefully that will get molecular testing closer to the first point of care seeking for participants. And if that's the case, then actually I think it's possible to collect a specimen without preserving it and then send it to CBNAT as long as that can occur within a couple of days. However, as we know, often there will be more time required before a test can be taken to a place where it can undergo molecular testing. And so in that case, there are a number of interesting innovations that I had the opportunity to view in the exhibit hall. A couple of those were mentioned before: the TB test card from WobbleBase, or the TB send card from WobbleBase, and then the TB detect and transport kit from MDI. So these are both kits that are compatible with downstream molecular testing. They render samples biosafe, and then they allow storage of the samples for up to 30 days in the case of the TB detect kit from MDI, and up to 6 years in the case of the TB send card. So this will preserve specimens, allowing downstream testing. Of course, the other application would be reflex to sputum culture. And in that case, I was also able to view the Biome Life product, which will also preserve sputum that can then be used in midget culture, for instance. So I think there are some really interesting new products that can ensure that samples will remain stable. I also think that there is further room to innovate with these products themselves. So in one case, the MDI product has a multiple filtration step, which could potentially actually concentrate samples too without any need for electricity. I find that really exciting and would love to see multiple additional specimen types tried with that technology. I think it's fantastic. It also has a very small footprint in terms of the amount of space that it takes up. It's about this big, so it's a very small footprint, which will make transportation easier. So I particularly liked that. Thank you.
Thank you, Emmy. So the important point which we need to take is like we should move from sputum based to non-sputum based sample collection and transportation. For that also we need to see how we ensure the quality in the collection and transportation. So that is where again more innovation and research is required. And also like as Emmy mentioned, like in the exhibition we had seen many tools in the area where the products are available for collection, transportation, and also concentration of the samples. And they are restricted to sputum samples, but that also needs to be explored in other non-sputum based samples, which would be the future research that needs to be taken up. Now I would like to move to Dr. Bharati ma'am. So like you mentioned about the sputum quality collection in the previous round. So what do you think that interventions could be played to see that how we can improve the sputum collection, quality of sputum that we collect, or the sample that we collect?
So I think it's more about how it is being collected, right? So the skill of the person who's actually educating the chest symptomatic how the sputum has to be given. So it's always good to have some, instructional videos or maybe educational videos which can be used to let people know how they're supposed to give a productive sort of a good quality sputum, good production. And there have been systematic reviews. They have been published that whenever you have good quality sputum, the positivity goes up. So this is a very critical area. And also, there have been studies which have shown that use of these instructional videos or literature, the education videos have helped in improving the positivity of the cases. So that's one thing. But second thing, more importantly, is that we have to now start thinking of people who will be very committed to do that work, because I see that this is a large country. This we have a huge population. We have services, we don't have much access because of different reasons. So, are we really thinking of a pool of people? We are talking about now about the village panchayats, for example. So, I'm coming from there. We are talking about engaging village panchayats. We are engaging village panchayats to create awareness. Why can't we use these platforms to actually inform them about how important it is to get good quality sputum, how important it is to build a pool of community volunteers within that village, you know? And when I come with that idea, I'm coming because, say, even if in a village you have 2 or 3 people who are committed to actually deliver to these services, so in every situation, it may be a pandemic, when you have lockdowns, it may be hard to reach areas, these people will always be available to provide these services to the needy there in the village. So it's not only about technology. Sometimes I think human carriers have always played a very important role, and we always talk about innovation, it's fine, but at the end of the day, it's the person who's going to do it. So if you till you don't have that pool of people working for you, I don't think whatever comes in is going to work for us. That's my
Thank you, ma'am. So that is where we need to see how we educate our patients through appropriate instructional videos, and also prepare a group of people at different levels for them to uh, deliver those awareness information or the educational videos, so that we get a quality sample. Then only they can be processed for testing.
Yeah, and let's not forget that now we are moving to another non-sputum sample, so which is like we are talking about tongue swabs, for example. So this is going to become even more important, because you will have to, educate the people, train them, tell them how to do it. So I think this is one area we really need to think of.
And also those videos should be at the local in the local language, so then only it will have more application and value. So those are the things that we need to take it forward. And now, Dr. Ranjani ma'am, so what do you think, the innovations that can be scaled up for overcoming these challenges that we discussed previously?
Uh, Thank you, Sriram. So, actually, while discussing all these things, some of them have already told some of the ideas in which we can actually innovate to collect samples, like the use of drone, use of human carriers, use of courier systems, use of postal services. So these are some things that we are already doing. It's not like it's not being tried. Each state is trying to innovate in its own way to do. But I think, for the uh, elimination program, because now we are in a stage where we are moving, where there is high prevalence of TB, then we will be moving to a lower prevalence of TB also. But our systems cannot suddenly stop because we become low prevalent, because even then we will have to keep doing sample collection. We will have to, in fact, actually our quality of samples have to be much more robust when we have a lower burden, because the detection limits then become lower. If you're reaching out to people at an earlier stage of the disease, the number of, so you will have possibulary states. So basically the entire program of specimen collection, I will not say sputum collection now, I will say specimen collection, because it will include sputum, it will include non sputum samples, it will also include non extrapulmonary tissue samples or fluid samples, everything, and including blood. So with all this innovation that is coming up, and actually many of us have seen in the display today, that there are a number of companies that have come up with the non-sputum samples from blood to urine to stool. So we must have a sort of an SOP that will cover how you will do, how to do, how, why, and how you will pack, how will you send. So that has to happen. In that process, it's much, states have come up now with sample collection systems which are very unique, where the NHM itself is funding many of these things, where they are having this hub and spoke model, where the testing laboratory receives samples from a spoke of, let's say, 10 feeding areas, which are collection centers from where these samples are being moved through actually humans using two-wheelers. Now this sort of thing is now becoming very prevalent in most of the states, where for blood samples, urine samples, it is very, it's very systematic. They know how to send it. There are boxes, those, all the collection tubes are, well packed. It is coming. But when we want to add sputum into this, that's where our problem comes. Because if you even look at the 50 ml container tube, it's completely in a different size. It has to be packed differently. Unlike a urine sample or a blood sample, this needs some special attention. It also needs, special packing if you are thinking of doing a culture. Now, and from where to where you want this to move. So also what has happened is, because the blood collection labs are at different locations, and our nat sites are in different locations, now people are finding it difficult, because this is not the route which they are following. Now if you want the TB sample to move, they are saying no, no, if it is not fitting into this, we will not be able to do. These are the challenges that, so states will now have to rework their entire hub and spoke model. It cannot be that for TB I will do something separately, for malaria I will do something separately, for leprosy I will do something separately, and for NCDs I will do something separately. And also we have to remember that the program has now moved to the lowest level, the health and wellness clinics, or our arm clinics. Now if we are saying that we want to reach to the community and we want people to come for screening there, and you want the CHOs to screen them using the CBAC forms, and you are identifying somebody who may have TB, then you have to collect the sample there. You can't keep telling them that I will do the screening, you have to go to that place to collect your sample. So these things are not going to happen. So our innovation has to happen, like even saying, these card tests, or even no dried sputum samples. We should really now think of innovative solutions, not only of transporting, but also how to collect samples in smaller containers. So I saw something today about, having a small tube where, they are concentrating the sample, and it's much more biosafe to send those things because it's already doing the decontamination. So can we think of robust systems where you can decontaminate the sample at the point of collection and move it along with the system? So this is one thing that we can do, piggyback on existing sample transportation mechanisms that are already available and already being paid for. So basically, you are saving on money, you're not doing one more step. Second is that, can we look at the private network of moving things? Now you can order something on Swiggy and you'll get it in 10 minutes. Anything from pin to pencil, anything you can get. So can we look at already existing providers who are already there? So there is Swiggy, there is Zomato, there is Amazon. I mean, anything you name it, you have it. True. But these all probably will work very well in urban settings. For the remote settings, can we really think of something that can be promoted through some innovative models, working with NGOs who are available there? Can we do something more for these rural areas? Can we train the tribal youths to actually do this? Can we use our TB champions to help us to come up with models where they will be available to support and collect these things? Now, two things are there. Everything cannot come as charity. So you will have to actually incentivize some of these things for sputum collection or specimen collection. So the other thing that I really want to address here is our difficulty in collecting extrapulmonary samples. Now, earlier we had discussed, especially I want to use the example of pediatric TB, where we had said that through the IAP, we will identify even private providers, pediatricians, who would be willing to collect that sample and send it to our laboratory. Now, that would be a package where you would provide for the disposables and for the consulting, where he has to do that. Now, we should have all these mechanisms. It cannot be that every time I have somebody, I'm saying, okay, you go to the medical college. So even in the medical colleges, we need to, unless if the nat site is within the medical college, we need to ensure that where a person will go for this collection. So it can't be that you go to this medical college, he keeps searching where that will place. So we need to have these very linked referral systems for us to collect these samples, and also look at out of the box thinking, that where we take the private sector in through PPM models, work with the private sector in a more collaborative fashion, so that the entire thing of sample transportation becomes seamless. Otherwise, what is happening is every time we want to do something, there is a big effort by the program to get these samples done, and also ensuring that the quality of samples, as Bharati has said, that without that there is no point in collecting so many samples. Then also we are also doing something through our mobile medical units. Now we should encourage that every time these mobile medical units go, even if they are not going for TB services, maybe this should be one of the things that you should push for, to ensure that these units are being used for even sample collection. So I think once we have a context specific with the diagnostic network optimization, we also know where the labs are, where the samples have to move, and mapping of all these facilities and the laboratory, and sort of, how would I say, a dynamic network that has to be optimized, context by context. But also probably we need to actually sit with the STOs and ATOs to come up with this with our private players, and ensure that this is done state by state, district by district. Thank you.
Thank you, ma'am. So already the organizers are asking me to conclude that, but to summarize, like as we discussed, like the first starting point is quality sputum collection, which comes with educational instructional videos, or more explanation which would make the patient give a good quality sample. So that is where we need to see that is done at multiple levels with local language, so that we first get good quality sample. Then the second point, which all discussed, where what is the purpose for which the sample is being collected, and to which test it is going to reach for getting the result. So that is where we need to see what is the mode of collection and its transportation that we need to plan. And the third thing, the context specific terrain and geographic, whether it is a hilly area, or is it a tribal area, is it an urban area, so that will determine the mode of transportation, where we need to see various options and delivery channels, to see that how we integrate with them or collaborate with them, to see that we get the results through the earliest possible mechanism, also introducing the digital interventions for tracking them with technology, QR codes and all those things. And also, like we should also be moving towards the non-sputum based testing, and also see that we have validation network for validating this sputum collection and transportation mechanism, so that they are having more robust evidence to be scaled up both nationally and internationally. And the last point is, for future, we need to see that all this sputum collection and transportations tools which were displayed in this exhibition and elsewhere also needs to be undergoing their assessments for non-sputum based samples, and also different types of pulmonary and extrapulmonary samples, so that it could be used at large. And also the important thing is that we need to see where it is positioned, for what it is going to be used. That will determine the use case, and the larger people would be getting benefited from that. So I would like to thank all the panelists for their extremely valuable insights, and providing the suggestions. Thank you very much, ma'am. Thank you.
Thank you so much. And I know it's been a rushed session, but nevertheless very intense, and a lot of inputs from the entire panelist. We'll request the moderator to hand over a token of appreciation to everyone. एक मिनट यार, ये दे देते हैं, it will not look.